All right, so you are good to go whenever you choose to, but feel free to wait just a couple minutes.
Okay, sounds good. I'll wait a little bit. I'll probably just give it like one more minute for people to join and then I'll get started. All right, I'll probably start now. Hopefully everyone can hear me okay. My name is Nicole Gibbs. I'm an internist, and today I'm going to be doing Journal Club about ureteral stents and retained ureteral stents. I picked a human article, so I did include, in the most part, that they have like the icon. Some of the slides have the icons like a human or a dog. So if people join as they come. Hopefully they'll notice that. Or if you're confused about whether we're talking about humans or dogs, just look up in the corner for them. So we're going to talk about retained ureteral stents today. I did this based on this article that's out of Urology Practice that talks about the impact of retained ureteral stents on long-term renal function. And this is out of obviously a human hospital that's at Texas Tech University for them. So when we think about ureteral stent complications, in human medicine, they can group them into less than 6 weeks or more than 6 weeks, thinking about short-term and long-term stent complications. And some common short-term ones, I guess they can go into long-term, is like irritative bladder symptoms, lumbar pain, hematuria is definitely usually more common in the short-term stenting, as you can see, compared to like long-term stenting for them. And then some of the more long-term or kind of more of the long term is whenever they're migrating for them. If they obstruct, tends to be a little bit more long term, although there is some short term. And then incrustation does tend to happen more long term. Urinary tract infections can happen on either side, so that one's both a short term and a long. complication for them seen in human. But I thought this was just a good chart that shows overall it's based off of a study. It uses the double J ureteral stents, which is what I've used in practice most often and seen most often in practice are the double J stents. And this one was based on 50,000 procedures. So obviously a lot in human medicine and becoming even more common both in human and veterinary medicine after procedures. So just important to know kind of major complications that are seen. So when we think about short-term ureteral complications in people, one of the most common and one of the ones that decreases their quality of life the most is the irritative voiding symptoms, which happens in about 42% of humans that have the double J stents for them. For these, some of the most common symptoms are increased urinary urgency or frequency, incontinence, hematuria. They can get bladder pain and renal colic for them. As all kind of part of this syndrome. And this is seen in higher morbidity if the stents cross the midline of the bladder and they have incomplete loops at the distal end, so at the bladder side for them. So just something to keep in mind when we're replacing stents is kind of what's seen in human medicine, which is that probably the longer, if they crossing midline, for them might be more likely to cause some of the irritative voiding symptoms for them. And something to keep in mind, I'd say we probably don't see as much like the 42% as humans do, but definitely all possible with when we are replacing a ureteral stent in dogs. In addition, there is lumbar pain in about 19% of humans, and I feel like we are not very good in veterinary medicine about picking up on certain pain in some animals for them. So this may be an under-recognized condition that we in dogs, but it is found that it's due to reflux from the urinary bladder in towards the kidney that increases intrapelvic pressure intermittently, leading to the lumbar pain that's seen. So there is reflux as a possibility as part of these stents, which makes sense because you're kind of opening up that area or dilating the ureter, but something to keep in mind in our patients. For long-term stent complications, in human medicine, when we're talking specifically about like the double J stents that this one study was talking about, they recommend replacement usually after 3 to 6 months. There are certain stent types that are they at least have on their labeling that it can be up to 12 months for them, but most of the stents are actually not labeled for more than 12 months for placement in them without needing replaced. So if longer, there are more likely ureteral stent complications in humans, including migration that can happen either proximally towards the kidney or distally into the urinary bladder. It's no longer in the kidney. There can also get ureteral obstruction, potentially station, which is a major problem in them where they have mineralization around the stent. In addition, the longer they're in place, the more likely they are to form urinary tract infections, which can also predispose to incrustation. So a lot of these kind of work together to lead to the complications that are seen with these. So they don't just have to have one complication, they can have multiple from these. And then ultimately, the longer they're in place, the material starts to break down and they can get fragmentation of their stent, which, obviously that could lead to retained stents within the kidney or difficulty removing the entire stent, which might lead to surgical procedures for them. What I'll talk about next is stent incrustation, because this is a major complication in these longer term stents for them. And this is when there's deposits of mineral crystals onto the surface and lumen of the ureteral stent. This increases risk of fracture of the stents and can lose their tensile strength. So that is the reason it fractures, is because it's no longer that material that the stent is made out of will be more likely to break down if it's encrusted. It becomes more firm, not as pliable, and then can actually lead to ureteral avulsion as well. And there's been some reports of even migration and things like that occur, or kind of avulsing out of the ureter. And ultimately, the incrustation can become so bad that it actually obstructs the stent itself and can lead to the problem that we're usually treating with this, which is the ureteral obstruction. There are multiple additional procedures that might be necessary if incrustation occurs for them. And I just thought it was interesting that up to 16% of lawsuits in human endourology are from retained stents for them. So it is a big deal in human medicine for retained stents. And I think in veterinary medicine, we tend to have more retained stents, or people that maybe don't remove their stents, or that we're treating longer term with stents. So for risk factors of what predisposes to stent incrustation, some risk factors include, as I mentioned, stent duration. So the longer the stent is in place, the more likely it is to have mineral form around it. In addition, if there's bacterial colonization, that can also increase the risk of mineralization. If you think about your struvite formers, if they are colonized with like a staph pseudointermedius in our patients, or something like that, that can increase the risk of incrustation. And then the physical characteristics of the stents, which we'll talk about in a little bit, is the difference in some of the types of stents for them. So stent duration for incrustation, about 9% of stents will have incrustation by 6 weeks and 76% within the 12 weeks. So within about 3 months for them. And in a different study that looked at even before 12 weeks, they had 30% incrustation rates with 4% obstruction rate. So despite them being somewhat encrusted, a lot of them will remain patent for a period of time, but keeping in mind that this is really only human patients and not looking at kind of longer term for these. For bacterial colonization, 90% of stents were colonized by 120 days for them. So by about the 6-month mark, most of the stents are colonized, which is interesting. And that it's linearly related to duration of placement. So the longer a stent is in place, the more likely an infection is to occur on that stent. And of course, with the stent in place, that becomes a lot harder to clear for them and might warrant replacement at that time. The smaller stents have also been shown to have more incrustation, so less than 6 French have higher rates of incrustation. Thinking about our patients tend to have those smaller stents for them. I don't think many, like I think at our hospital, we don't carry more than 6 French for them, so that is pretty common for ours, that they're the smaller stents, so maybe they're more likely to have incrustation. And then material composition does play a role. So I'll talk about the different materials now for the stents. So polyurethane is probably the majority of stents that have that are used in human medicine as well as in veterinary medicine, I believe, or at least in my experience. There are different, so they're usually a polyurethane base, but there are some proprietary blends that make it a little bit difficult to have one-to-one, looking at these across studies. There's silicone stents that may be becoming more common because in vitro they've been found to have less of a incrustation rate. So at 10 weeks, only 69%. So still a very large proportion had incrustation, but 100% happened with the polyurethane or the other materials. These were considered least susceptible to have calcium and magnesium deposit, so less incrustation, and they also have lower biofilm formation, like 20% for them. So silicone is a good option for these stents and might be becoming more common in human medicine for these. There's also metallic stents. These are used more for malignant obstructions in human medicine because they're able to withstand better extrinsic compression for them. There's something called a resonant stent, which is a type of metallic stent that has about a 1-year patency. So that's the one that's labeled for longer, so about a 1 year, versus most of the other stents are recommended to be replaced after 3 to 6 months for them. There's also some reduced incrustation with the metallic stents as well. And then, as with, I feel like a lot of things that people are trying coatings for these, so a lot of the implants will have certain coatings, some of which are being used to reduce incrustation, some are used more for bacterial. So there's a lot of different options out there available, but the ones that are mainly used for incrustation have a glycosaminoglycans that can reduce the rate of mineralization of those stents for them. When thinking about incrustation, they actually grade it in human medicine. So grade 1 is these like linear incrustations on the pigtail. So like the dark black recommend is the mineralization that happens for them. So grade 1 is just a linear incrustation on the distal end. Grade 2 is that it encompasses like the whole pigtail of the stent. Grade 3 is that it has the pigtail and linear component towards the ureter. Grade 4 is that both of the pigtails have the incrustation on them. And grade 5 is basically this whole stent is fully covered by incrustation. And depending on the degree of incrustation does depend on what is decided of what to do about the stent and what are possibilities. So they do both CT and some ultrasonography. Sometimes you can see mineralization just on radiographs alone for them, but I would guess I don't know as much what their imaging they choose, but I would guess CT is the one just from images and like studies I've looked at. So if there is less than 5 mm coverage and like, or less than 5 mm of mineralization, and they have less than 50% of the stent coverage, they will attempt cystoscopic removal of that stent and then replacement if needed for them. However, if it is more severe, where there's more than 5 mm of that incrustation or more than 50% of the stent is covered, they do usually have to do additional procedures. So extracorporeal shockwave lithotripsy is an option that is used when the stones and the mineralization is less than 1.5 centimeters. A percutaneous nephrolithotomy is used when it's greater than 1.5 centimeters. They can also use laser lithotripsy depending on what is used, or lithopaxy for them can be used more on distal stone burden. So depending on where the stone burden is and how severe it is depends on which procedures, but the more severe, the increased number of procedures are needed to address these stents incrustation. I just thought this was an interesting one that shows how they decide on which stents to potentially use in each patient. So it says like what the underlying disease is. So like stone disease, they use silicone, or the PU is polyurethane, and what type of like the coatings they can use for them, versus like if they have something like strictures, which are more long-term, they want more likely to use like a copolymer one or other materials based on this chart for them. And then malignant is the one that they tend to use the like nitinol material for them, and can have different coatings. So I think that's interesting because I would say, at least in my hospital, we keep one type of stent in stock for them. And I'd say the most common use is the stone disease for them. But potentially, if you're going to have more of a long-term stent, should we be using different stent options, or at least like look at the availability of them for more long-term use? There has been a report in dogs of addressing stent incrustation, where it was an 8-year-old Dalmatian that was evaluated for recurrent UTIs 3 years after stent placement. The stent was originally placed due to ureteral tear, secondary to ammonium urate ureteral lithiasis, of course, it's Dalmatian. They did recommend removal of the stent, but the dog was lost to follow-up for them. And so when it was seen 3 years later, there was about 3 UTIs that continued to occur that all grew staph pseudomedius. They did an abdominal ultrasound that showed a right hydroureter and pilectasia. There was also on the cystic component of the ureteral stent, the stent was encased within the calculi. So this is just what their radiograph looked like. So I don't know how well this can be seen. You can see it actually probably migrated as well because it doesn't loop into the renal pelvis as you would expect for but also that there's this stone material that's pretty much encasing the ureteral stent at that point. So in this study, or in this case report for dogs, they did use lithotripsy for it, and so we're able to break down the mineral around the stent, and we're able to, they pulled the stent into the urinary bladder and then pulled it out from the proximal end, because as I mentioned, the mineralization will increase the risk of fragmentation of the stent. So if you do have one that's fully encased, might be helpful to kind of pull above that mineralization and then pull out of the bladder with the proximal side instead of the distal side, which is usually utilized for this case did have ammonium urate as its like nidus of infection. Again, not surprising because it's Dalmatian for and then they were able to, one, remove the stent and removed it fully, yay, but also were able to remove all of the mineral debris with lithotripsy and voiding urohydropulsion. So no surgery needed for this dog. But I thought it was a good example of the stent incrustation that can be seen in dogs as well. So we'll move back into the study, which talks about these retained ureteral stents and other potential sequelae for them. So then the materials and methods, this is a retrospective human study, and they collected data from 2003 to 2016 for them. They had a total of just about 1,600 patients. In the retained group, there was only 34 patients, 40 stents, so 6 of those were bilateral stents. And then they had their control group, which was randomly selected for them. And they had a total of 104 patients, and a retained ureteral stent was defined as greater than 6 months in place for them. For these, 25 had to be removed in the control group, so they ultimately had 136 stents total, 16 of which were bilateral for them. So 120 patients overall were in the control group versus the 34 patients that were in the retained ureteral stent group. They got a ton of baseline characteristics, including age, gender, state, distance from hospital, what financial class they were, duration of stent placement and reason for that, what their creat and estimated GFR were before and after stent placement, whether they were diagnosed with CKD or not, and then they look for things that might predispose to CKD, such as hypertension and diabetes, as those are big predispositions in human medicine. Their primary endpoint was looking at the percent of patients who were diagnosed with new onset of CKD 3 months after ureteral stent removal in both groups. CKD was defined as a creatinine above 1.3 and or an estimated GFR less than the 60 mils per minute per 1.73 meters squared for at least 3 months. So not an acute injury, they waited 3 months for this chronic injury. Their secondary endpoint, they wanted to also look at the number of OR sessions that these patients had with the more retained compared to the control, and whether they were more likely to be admitted to the ICU or ER for UTIs and sepsis after stent placement. And sepsis for them was defined as the SIRS with suspected UTI using the human 2001 definition of sepsis. For their statistics, they had univariate analysis using Fisher's exact test for categorical variables, and then they had continuous variables. They looked at a t-test, a Welch t-test. They used a software called SAS, and then the p less than 0.05 considered statistically significant. For the results, they did not find a difference in demographics, so there was no difference in the retained or the control group for financial status or for age for them, or reason, or any of those kind of other, like sex or anything like that, did not play a role in their controlled versus persistent. The median follow-up time after stent removal was 11.5 months in the retained group and 44 months in the controlled group. I think that makes sense because if they were in the control group, they probably adhered more to their follow-up plan. And so they had a little bit more follow-up in the ones that were in the control group versus the retained group, which probably were not the most adherent to their recommendations. There was, though, when they looked at them, the difference in the reason for stent placement, although both groups, the majority was due to stone disease. In the retained group, there was more likely malignancy for them. So about 14% of them had malignancy versus the 6%. And then they had more other as well in the retained group compared to the others. For duration, so the median duration was about 14 months in the retained group versus about 1 month in the control group, so 32 days for them. The range for the retained group was all the way up to 146 months, so a really long time for these to be in place. And then they looked at chronic kidney disease development, and they found that in the retained group, 26% of them had developed chronic kidney disease versus 3% in the control group for them. So having a retained ureteral stent had an odds ratio of 8.64, so 8 times more likely to develop CKD than if there's not a retained ureteral stent. And looking at comorbidities for them, they did not find a difference for hypertension and diabetes mellitus as potential confounders. So they thought that that the CKD difference was due to the retained ureteral stent, although there's many causes of CKD. This is just their figure that broke down the different cases that had it. So these are the 34 patients that had a retained ureteral stent for more than 6 months. 32 of them developed CKD for them, and then they looked at how many had it prior to CKD or had prior CKD before stent placement, and only 2 of them did, versus 26% of them had newly diagnosed chronic kidney disease after removal. It's compared to the 120 with non-retained ureteral stents, where 9% of them had kidney disease after removal for them, but they had a higher proportion that had kidney disease before, or a higher number, at least overall, for it. So overall, they found that CKD did happen more in the retained ureteral stent group. They also found, which has been documented in several studies, that the ones that had retained ureteral stents had higher rates of hospital admission for UTI and sepsis. For the retained group, they had 30%, almost 30% were admitted to the ER, ICU at some point for UTI and sepsis, versus in the control group that did not have retained ureteral stents, only 10% of them had UTI and sepsis. The retained group also required more OR sessions for successful stent removal. So as I mentioned, the incrustation usually increases the amount of time or the amount of procedures that are necessary to remove their stent. And so in the retained group, almost 20% had to have at least 2 procedures versus 4% in the non-retained group. And this could be a combination of pretty much any of those procedures, so extracorporeal shockwave lithotripsy, ureteroscopy with laser lithotripsy, or removal of the stones from the urinary bladder. So overall, from this one, the cause of retained ureteral stents they thought was due to poor patient follow-up or from inadequate patient counseling. There was several limitations of the study, including that it was a retrospective study. There was a low number of cases. Like for us, this probably is similar amount of cases that we would have, but for human medicine, it's quite a low number of cases. And then that development of CKD was multifactorial, and they didn't necessarily they looked for hypertension and diabetes as a potential cause, but they did not look for, more causes of CKD for them. So there could be multiple factors, not just the retained ureteral stent, that increase the risk of having CKD. Overall for this, I thought there was a disappointing amount of data. Like it would have been nice to see their degree and progression of chronic kidney disease, the time to which that occurred, which I'm guessing might not be possible if they didn't lacked follow-up for them. And they didn't necessarily fully address like the long-term sequela of the CKD that developed for them. But overall, retained ureteral stents are a big problem in human medicine, and they are leading to development of dissolvable stents for them. So that was this study. I was going to mention, I have a couple slides on the ureteral stent outcomes in dogs, because there is a paper out of JAVMA from 2018 that was a retrospective on from Animal Medical Center in New York City for them that looked at benign ureteral obstructions. Ureteral lithiasis was the most common cause of these. They had about 44 dogs, so they actually had more dogs than in the retained stent of humans, but there was only, as retrospective data, they only looked at dogs that had ureteral stents. There was no control group for this. they had 59% had UTI prior to placement, and there were complications that were reported, including hematuria. Stent migration happened in about 5% of cases, or 10% overall. Urinary incontinence occurred, UTIs occurred in about 26% long term, and then occlusion of stent in 9% for them. Interestingly, I thought the incrustation was only reported in 2% of cases, but I do wonder if this is under-recognized for our patients for them, just because of the really high rates in human medicine and how long some of the stents are in veterinary medicine, that the incrustation, if we don't necessarily look for it on imaging, or if we're not removing them to look at the degree of incrustation, then maybe we would miss it for them. They did note that in dogs, there was replacement in about 12% that needed stent exchange, and 5% needed sub-placed ultimately, with a median time of 139 days. Looking at UTIs, 59% had them prior to even placement of the stent, but after stent placement, 26% of them had a UTI after 1 month. So a different, or a persistent UTI for them at that time. 72% of the patients that had UTIs were able to clear that infection, but 28% had recurrence with their ureteral stent. Looking at their follow-up, they did have a really long follow-up, which was nice. So about 1,100, over 1,100 days, with 70% being alive at the time of last follow-up. They did look at creatinine 3 months after stent placement, and its median was 1.3. Looking at it 6 months after is 1.2, and time of last follow-up was 1.2. So the median stayed about the same throughout the duration of the follow-up time, although there was not necessarily individual data on changes for them. They did report that 15% of their patients in this study died of suspected or confirmed progression of CKD for them. There was not necessarily data on what that progression looked like, or was it the ones that already had later stages of iris. But they did look at the outcome and showed that pre-op BUN and creatinine, pre-op iris stage, and development of long-term complications did lead to a poorer outcome. And then factors needed for exchange was the cause of obstruction. UTI before placement led to more exchanges, and then the stone type with calcium phosphate was, I believe, the stone type that was more likely to need exchange for them. So as I mentioned, about 15%. I already said this slide, so apologize for that. But I think things to consider are like part of the discussion. I think one of the considerations is like ureteral stenting in young dogs, or like ones that need them, and considering having long-term treatment plans. Is it something that people would pause about, or trying to think of a more long-term solution versus these ureteral stents that can have some of the long-term complications that occur, potentially younger dogs. We need to be searching out, especially more often, the long-term treatment plans, and maybe having, there are a couple of patients that you lose to follow-up with ureteral stents, and I do think, I've definitely seen them come in years later, like that it was placed somewhere else, and we see them there with a ureteral stent that now has a stone. And so I think it's a consideration of something to talk to clients about, and what making a long-term plan for them, as opposed to just having it. Kind of leaving them with their stent after they're unobstructed, and the clients think everything's fine and that everything will continue to be fine, but talking to them about more of the long-term complications is definitely something I would take away from this. And I do think potentially there is the case report of the incrustation. I do think that's something that we could potentially start seeing more of as we have increased stenting that's occurring in veterinary medicine. And so incrustation, will probably see more of it. I wonder if it is like an under-recognized component of this. And then what would be nice, but I think we're probably a long way from, is looking at progression of CKD in dogs with ureteral stents versus like a control group, to see, do we see similarly in veterinary medicine that there's a progression compared to just in human medicine, especially because I do think our ureteral stents tend to stay in longer than in human medicine. So that was kind of my thoughts, and I'm happy if anyone has any questions or other thoughts, or things they might have seen in practice.
Nicole, this is Jenna here. I think you did a really great job, great article to discuss. And I think you're absolutely right. I mean, I think part of it is we don't have enough literature to support evidence-based guidelines for how we should follow these dogs and at what frequency we should do stent exchanges. I mean, we just don't have a body of evidence for an expensive and not necessarily benign procedure. I mean, most of them go great, but things can happen. And I think the exhaustion from clients when they've dealt with complicated stone cases for a really long time, to then tell them we're going to do a stent exchange every 3 months is a lot. And regarding the, I think it's interesting that with humans with these long-term stents, progression of CKD, I think that's a challenging thing with our patients because we know calcium oxalate stone is, going to be the most common stone type that we're seeing overall. We know that tubular handling of calcium leads to CKD. And the ones that get ureteral obstruction and have that hit to their kidneys are likely going to have, that's one more hit than an average dog with CKD who isn't a stone former. And so the progression of CKD in the dogs that have stents, is it because of the stent or is it because of their underlying disease? And they're the worst stone formers to begin with. I think that's going to be really challenging to tease out. And, I think along that is, what therapies can we do to minimize stent complications and also their CKD progression? I think we're a long way from answering those questions, but so I don't have anything helpful to say. We stent a fair number of cases here at A&M, and I have seen horrible incrustation and way faster than I had hoped. I had a case that's now burned into my brain that was a compliance issue. We told the owner to come back in, I think we said 3 to 4 weeks. It was a struvite ureterolith, and the dog didn't come back for about 2 months. So not insane time period. And we ended up having to take the dog to surgery because it was like a 3-kilo Chihuahua and with complete incrustation of the distal aspect of the stent. And the surgeon said it was like an onion ring. Like she had to like hold the stent in her hand and like peel off this crusting, and it came off, she said, just like an onion. I mean, she showed it to me. I mean, it really was like this onion ring crust. It was disgusting. Yeah, you never eat onion rings again. But it was all struvite, but it was, when we think about struvite, stone formers having it happen really fast, but the incrustation and how thick and hard, and like this thing was just a onion ring rock. And that was very impressive to me. And so maybe we're not checking them enough, and maybe the oxalate formers do this less, because we see some of these cases for a long time who don't seem to encrust nearly as quickly. So anyways, those are my thoughts, and I thought you did a great job. Thanks for making me smarter. If you have any additional thoughts for me, I'd welcome them.
No, yeah, I agree. I think that why we probably lose some of ours to follow up is like owner exhaustion, and also that, it costs money anytime we do some of these procedures. So I think asking them to, one, if it's ureterally obstructed that they have to be hospitalized for, then telling them like, okay, then we need to plan a separate procedure to take care of this ureteral lift if it doesn't pass and things like that. I think that all like weighs into it. And I agree with you. I think progression of CKD, we are a long way from figuring that out for our patients. Yeah, so I think I agree with everything you said. And I've seen some of them mineralized, like you said, that went to surgery, and then they have like this huge, like, and it was a calcium oxalate former, but then had a struvite stone from a UTI. And it was like 3 years later after the stent was placed. So I think it's so interesting, the mineralization. And in 2 months, I would not have expected either on that one case, the onion ring case, which is now how I'll refer to it.
I wanted to say thank you as well. And Dr. Chingy and I are starting to pull cases from our hospital, and then her hospital and her hospital system, sister hospitals, to look at stent complications. So we are an early work in progress. And certainly anecdotally, I can share, yes, we've seen a number of major complications where we place a stent intending to do a subsequent procedure. The owner didn't come back. And when it does come back, the stent is encrusted and adhered to the stone, can't remove it without breaking the stone up, etc. So, yeah. And this is very helpful. Thank you.
Yeah, absolutely. The more studies, the better. So I think that sounds great. Looking forward to seeing that one. Anyone else have any thoughts, experiences? Check the chat real quick, but yeah, thank you guys so much for attending, and I appreciate your guys' insight into it. And yeah, hopefully more to come as I think more and more people are doing ureteral stenting. So I think more to learn from human medicine and hopefully from our own patients.
Great job,
Thanks,
Nicole.
everyone. Have a good rest of your day.